Everyone, welcome to Clinical Problem Solvers Thursday 30-minute VMR. My name is Promise. I am a third-year medical student, just finished my first rotation, and I'll be starting surgery next week. And today I will be facilitating with Ravi discussing the case. Does anyone have a case?
Promise, hello. I'm both delighted to hang out with Promise today and a little bit sad because we were going to hang out last week, but COVID exposures unfortunately took over that day. But it's great to hang out with you, Promise. You guys must know that Promise is probably the most junior in terms of medicine exposure CP Solvers team member ever. She joined us as at the end of her first year, right? Or beginning of your second year, Promise?
End of my first year.
End of your first year. Can you imagine that? MS1, like so enthusiastic and ready to learn, and here she is, almost a couple of years later. We're super excited to share the stage with you, Promise. And the good news is Andrea has kindly stepped into the case presenter role with an alley-oop by Ravi. So Andrea, do you want to introduce yourself to the crowd, and we'll jump right in afterwards?
Hi, I am Andrea. I am a medical student in Lima, Peru, and I am currently doing a rotation as an internship in Sinai Hospital, Ravi Singh, and I am applying to the match this year.
Amazing, Andrea. Well, this whole community is rooting for you, and I hope that you're having a great time with Ravi and his crew. Oh wow, the whole new conference crew is here. Okay, incredible. All right. Andrea, please take it away, and we'll get going when you're ready.
Okay. So the chief complaint is a patient presented with masses over her hands and upper and lower extremities with erythematous rash that developed over the course of 4 weeks. With erythematous rash that developed over the course of 4 weeks. Erythematous rash.
Do we know the patient's age, Andrea?
56.
Okay. So I guess I could start, Ravi, if you don't mind. So I think for me, first of all, rashes is not my strong field, but I think the first thing I notice is that this is something that is chronic because it's been around for 4 weeks and it's not just localized to one area of the body. It seems like it's both upper and lower extremities. And there's like is also erythematous. And this patient is 56 years old. So something that comes to mind, I think I would think about like maybe like an autoimmune or malignancy. It could also be infectious, but it would be more like a chronic infectious process. I think right now I just wanted to ask a lot of questions, and the questions include, like a physical exam to learn more about what this mass looks like, the qualities of it. I wanted to know if this patient has a fever or not. I wanted to know their exposure history, and then also their past medical history. And let me see. Also, if we go into lab, I would want to know their CBC, and kind of start thinking from there. So I think right now I am just asking a lot of questions, and I don't want to start thinking about differential diagnosis too early. I just want to start really broad.
Promise,
That's just my thought process right now.
I completely agree with you. In medicine, if all of you have either heard of or are taking care of patients, and if you go back to the moment you start talking to a patient, your differential diagnosis doesn't just begin when they start talking. You only start to formulate a differential diagnosis once you have a clear understanding of what the problem is. So if I come into you and say, hi, I'm having a little bit of abdominal pain, it's not like you immediately start to say cholecystitis, diverticulitis, appendicitis. No, you start to ask some more questions. And so in medicine in general, there is the problem characterization phase of diagnostic reasoning, and there's a problem resolution phase of diagnostic reasoning. And Promise, I completely agree with you. Right now, we don't know what the nature of this problem is well enough to start solving it, right? we know that there is masses involved, we know there's a rash involved, but that does not give us an adequate problem representation to begin to solve the problem. And I think the key questions are exactly what you said, which is what is the nature of the masses? Where are they located exactly? What is their color? What is their depth? And the same thing about the rash. Where is the rash located? What is its depth? What is its color? So on and so forth. So there are many, many, many aspects to first understand the problem. And only when we can really say we understand the problem should we begin to solve it. So maybe what you and I can do, Promise, is just to vocalize the moment we think that we understand the problem in this case, just to make it clear to everybody. I think it'll be a little while, but let's try to outline, are we in problem description or problem resolution? And right now, definitely problem description. So we'll ask Andrea to tell us more about the problem.
Okay, the second aliquot is a 56-year-old woman with a history of asthma, presented with masses over her hands and upper and lower extremities with erythematous rash. That the lesions developed over the past 4 weeks. She was on multiple courses of prednisone for asthma and later transitioned to dupilumab 6 weeks ago. There is no itchy, irritation, or pain. She has had malaise, generalized weakness, nausea, constipation, and fatigue over the past few weeks. No fevers or weight loss.
Okay, so let me just try breaking down all of this information into small bites first. So something that jumps up to me is her history of asthma. And let's see, and she was on prednisone. So with prednisone, I know that you could have like striae or like some kind of skin findings with it, but I don't think you would have masses over. And I would be interested to see if the timeline matches with when her masses start to appear, or at least like the erythema starts appearing. I feel that the nausea is something that and the fatigue and constipation are things that I would want to focus on more right now, because they are more alarming, and I think that's kind of where I can make more progress with it. Like with fatigue, I would think, okay, does this patient have anemia? Or is it like a pulmonary? Is it just from asthma? Like a dyspnea cause of it? And then with nausea, there's like a whole thought train of, is there anything wrong with, neurologically? Is it like an increased intracranial process? And with constipation too, then I'm kind of like, my head is going into like, is there autonomic, or is she on some sort of medication that makes her constipated? I think it's good that she does not have fever and weight loss. That brings me a little bit further away from like an infectious process, but I'm still putting like malignancy in the back of my head because of her fatigue. But that's kind of where I'm at right now. Help me out, Ravi.
Well, I don't know if you need help, my friend. I would just say that it's very hard for us to start to solve the problem yet. I don't think that my mind is generating any diagnoses or even categories, honestly, because everything is still possible. And I think you hit the nail on the head. There's two things that are different now. One is that you have a patient who is potentially immunosuppressed with large doses of steroids. And so the immunosuppression here is notable, and that opens up a whole category of possible complications related to steroid use. And then the other thing that you learned is that this is not just a skin problem, that this patient also has visceral symptoms, nausea, constipation, and fatigue. And you might make the mistake of translating those symptoms into GI symptoms, because nausea, constipation, and fatigue are most commonly referred to the GI tract. But as you did, you were broad. You were like, no, the nausea could be, there's a whole thought train of nausea. So I think we are still in problem characterization. I think it would be a mistake to try to solve the problem now and invoke categories of diseases or specific conditions. And so all that I'm trying to do is to understand what is the nature of this problem by now understanding what does the nausea, constipation, and fatigue fundamentally mean. And I'm sure that'll be elucidated on the labs for sure. And on exam, we'll understand the rash and the surface manifestations, and then we can start to say, okay, this is the problem. The asthma potentially could be an important part of this case, but it's so common to have asthma that it may be completely unrelated and an innocent bystander. So what do we have here? We have a systemic syndrome with potentially GI features that features the skin in a patient who is on prednisone. Again, that problem representation isn't adequate to beget any individual diagnoses. So you still need more data. What is that data? Understanding the surface manifestations better by an exam and understanding the visceral manifestations better with labs. All right, Andrea, back to you.
Okay, so in past medical history, we have, of course, asthma, sleep apnea, hypertension, and hypothyroidism. Social history, no history of alcohol, tobacco, or illicit drug use. Family history, the son has heart disease. Surgical history, none. Allergies, none. In medication, she's in albuterol, dupilumab, lisinopril, hydrochlorothiazide, and levothyroxine. In physical exam, we have temperature 97.8, heart rate 78, blood pressure 121/92, respiratory rate 16, oxygen saturation 98. In the physical exam, what's significant in the skin, we have multiple palpable non-tender firm subcutaneous nodules and plaques on bilateral upper extremities, right hand and right anterior thigh, with overlying erythematous rash. In the neurology exam, there was generalized weakness but no focal deficits.
Wow. This is so interesting that now we can see that this patient has generalized weakness. Let's see. Okay, so if I have to break this down, I think this patient definitely has a history of pulmonary compromise. She has asthma and sleep apnea. But I think the thing that I really wanted to focus on is having this skin finding, but then with a neurological generalized weakness. So that kind of made me think more of like a systemic process, because you can see that it's not just the skin anymore. And then the vitals are pretty stable, so I'm not that worried about it. But let me see. The right hand, right anterior thigh. Is there any mass or anything that you find on the left side, or is it just localized on the right side? Or bilateral upper extremity, but what about the left lower extremity?
It's in both sides, the upper extremities, but the nodules, but the rash is in the right hand and the right anterior thigh.
So then for that, I'm curious, like my question is the nodule and the rash the same process, or are they two different things? And that I will pass it to Robbie.
No, I don't know either. I think that it is very interesting, right? That the patient has nodules that are, it seems, predominantly over the upper extremities, and the rash is somewhere else. So just based on the fact that they're located in different places makes one wonder that they're probably unrelated, but I don't know. I don't know the answer to that. And so I think that I think the safest thing is to assume they're unrelated and hopefully be proven wrong, because that would be a much simpler problem to solve. And I'm curious, Promise, when you hear these like diffuse nodules, what does that, if we focus on that arbitrarily, so what does that do for you?
Sorry, nothing is really coming up
Yeah,
in my
right.
head I feel like it's something really simple.
No, it's not. It's not simple at all. I think that if you ask yourself, what is the differential diagnosis of nodules, it's definitely not simple. I'm curious, what does the nodule mean to you? So when somebody has a nodule, what does that mean to you?
Like they have like lumps and bumps on
Yeah.
their skin.
Yeah, exactly. And the nodule, the term nodule implies that it's something that is like a pretty significant lump or bump. And I don't know what the exact definition is, honestly, but a nodule evokes the idea that it's something deep. So, you know, when people come in and they have papules or plaques or pustules, that is definitely a superficial process. So when someone asks me, what does a nodule mean to you? I don't really know. I don't really think I have a very focused differential diagnosis, but what it fundamentally means is nodules equals deep equals something that is really a sort of like an involved cutaneous process. And that's the simple takeaway that I would make is when somebody has nodules everywhere, the chances of you finding a specific diagnosis is pretty high. Now, that's in stark contrast to patients who have non-specific superficial rashes like erythema or plaques or papules. A nodule is thick, which means it's deep, which often means it involves the dermis. So here's the tension in this case. You have a deep skin process and you have visceral symptoms. So I think the chances of this being some kind of systemic disease that involves the skin is pretty high. Andrea, I think you, I'm not sure who's sharing the screen, but I think you might have accidentally opened some helpful slides. I promise you I didn't see the answer. Maybe you didn't, but I think it's yeah.
That's for
I
me.
looked away. I looked away.
Okay, good. Yeah, I was like, oh my gosh, are they good? Am I botching this discussion and therefore they're telling us the answer? But I think what you can confidently say is this person has a systemic disease with cutaneous manifestations. So I think the question is, what is that systemic disease? So what has happened, Promise? We started off with a rash. We then got some subtle symptoms that the GI tract is involved, or that there's systemic signature. And now we know that the skin manifestations aren't just some superficial stuff like plaques or papules. It's nodules, which means they're deep. And if you reflect on what I said to you, I asked you, hey, what does nodules mean to you? And you're like, I'm not really sure. And I hope you're seeing the fact that I'm not really sure either, except that I know that it means that the problem is a deep problem. And that deep problem probably links up with the visceral symptoms that we're seeing. Alrighty, Mike to you, Andrea. I think you're muted.
We briefly saw the image, so we're gonna continue with the labs. Calcium was 15, vitamin D 25 was 34.6, vitamin D1 25 was 83, PTH was 5.4, PTH-RP was less than 2, ACE was 109, and TSH was normal. In the CBC, the white blood count was 7.4, hemoglobin 12, hematocrit 37, and platelets 240. Test results for hepatitis B and C, syphilis, and HIV were all negative.
I don't have like all the lab normal values of the lab in my head right now, but I thought it's interesting that you guys like did like a vitamin D and parathyroid labs, and I would be curious to hear why you decided to go with that. Yeah, Robbie, help me out.
I'll guess. I think that the key abnormality that prompted all these labs promises the calcium of 15. Whenever you have a calcium that high, that prompts you to do a workup, including the PTH, including the vitamin D. So I think the conversation that we're having is, what does this calcium of 15 mean? So what do you think about that? that the patient is hypercalcemia?
Now that I know the patient is hypercalcemia, then I wanted to know why. And so it could be a parathyroid, like a primary parathyroidism or a secondary. And then this patient has vitamin D also looks very high. Um, and so, and her PTH, is that normal or is that
Yeah,
elevated?
you don't need to think about whether or not it's normal or not. That's not helpful for your diagnostic reasoning. So let me just tell you whether they're normal or not. So the calcium is really high. The 25 hydroxy vitamin D is low, less than 40 or 50, I believe. And the 125 hydroxy vitamin D is very high. So there's a disconnect between the vitamin D levels. The PTH is suppressed, very low, and the PTH-RP is also suppressed and very low.
Okay.
Thoughts on that? You're in
Yeah.
this situation as a third-year medical student analyzing one of the most complicated cases of hypercalcemia with these data points and a patient with a nondescript syndrome. And the truth is that you're knocking it out of the park so far. So I'm curious where your mind is with this very advanced data set.
So let's see. So the 125 is really high, and 125 is the enzyme in the kidney, if I
Yeah,
remember correctly.
exactly.
And then the other one, the 25, I think that's the step before the one that happens in the kidney, or is the one that happens in the skin. But I don't remember that. I need to review that. So
I
I
also
think
don't remember. I just know it's pre-kidney, but I don't know if it's in, I don't actually know. So
okay. So basically, something is like not making the conversion from there, but then for some reason the kidneys seems like that enzyme is hyperactive, which you have such high levels of 125 vitamin
yeah,
D, and then that leads to like a high level of calcium. And
yep,
then you said the PTH is suppressed, right?
yep.
Or is it okay?
Suppressed, yeah,
Which makes sense because when you have really high levels of vitamin D, it negatively feedbacks onto the PTH.
exactly.
So I think like endocrine wise, like the axis seems normal. So because the PDH is responding normally. So right now I'm mostly thinking about does she have some sort of like that pathway where some
Yeah.
kind of enzyme it's malfunctioning.
No, 100%. You've localized the lesion, my friend. And honestly, this is the key part is localizing the lesion. And you can Google the DDX for this, honestly. And so your knowledge base is advanced enough that you can take a complex calcium case and know where the problem lies. And you've clearly identified your growth point. Your growth point from this case is to then, for the next time you tackle this, know what the DDX of the abnormality of this pathway is. And as a third year medical student, many people's growth points is actually understanding what the pathway is. And so knowing that that's the lesion here is very, very advanced, not the least bit surprising. So what does it mean? It means this abnormality means the patient has some sort of granulomatous disease. And the question is, what is that granulomatous disease? Why is it a granulomatous disease? The only time that vitamin D can be pathologically converted from its 25 form to its 125 form is when that enzyme is secreted from outside the kidney. And that only happens when you have a granulomatous disease. So Promise, what are some of your favorite granulomatous diseases?
Well, all the participants in the chat have been helping out, and
Yeah.
I also noticed that ACE is like elevated, and with the chat solve, I think that's like very the first one with all the nodules that and the rash that comes to mind, and the weakness would be like sarcoidosis, and also because this patient is a female, and then she also has like asthma, and she was on prednisone. And then she switched to a different medication 6 weeks ago. So the timeline sort of matches up. Like when she switched that medication, like the prednisone is no longer suppressing this process. So then she shows some symptoms. But I don't want to anchor too early. If there's one thing I learned from all these morning reports is don't anchor too early.
I completely agree with you. I think that you have to be very careful here. because you do have a patient who has some granulomatous disease process, and I think when that granulomatous disease process begins as abruptly as it did in this person, you have to think about sarcoidosis, as was alluded to. But you have to be careful. There are many things that look like sarcoid, lymphoma, and certain infections do it too. And here, I think the strongest argument against sarcoidosis is that this is happening in a patient who's getting prednisone. And so that should really weaken the notion. That has to be tempered with the fact that most patients with other granulomatous diseases don't get so sick so quickly. Abrupt onset masses over the course of such a short period of time. So I'm right there with you. I think all that we can confidently say is this person has some granulomatous disease. The time course suggests sarcoidosis. The probability of a granulomatous infection or cancer is something that, as you emphasized, we can't let go of. So I think that's where I'm at. Andrea, take us home, please.
A punch biopsy from the left lateral forearm was performed, revealed a normal epidermis and a deep dermal inflammatory infiltrate comprised of well-demarcated granulomas embedded in a dense fibrotic stroma. The next aliquot will reveal the diagnosis.
All right, Promise, what do you think? You're now a pathologist.
Okay, well, the biopsy shows that this patient has is an inflammatory granuloma. So I think right now, like, sarcoidosis is the highest on my differential.
Yeah, I completely agree with you. I think whenever I think it's hard not to have sarcoid as the first differential diagnosis. I think that it's easier to do that in a patient who hasn't traveled to areas where the sarcoid mimickers like TB and endemic mycoses are at play. It's easier, and we don't have that history. But the one thing that you'll always have to recognize, and this is a pearl that I learned recently, is about 15% of patients who are diagnosed with sarcoid ultimately develop a lymphoma within the first 5 years. So just like patients with dermatomyositis have an elevated cancer risk that may show up 5 years afterwards, that is true for patients with sarcoid. So I think we can say our working diagnosis is sarcoid, but open to the possibility that there might be a lymphoma that may not be present now, but may show up within 5 years. But I agree with you. I think this patient has an inflammatory disease like sarcoid. All right, Andrea, take us home, please.
The constellation of clinical findings together with the histopathologic changes represented the Darrier-Roussy disease variant of sarcoidosis. You were right. She was started on steroids along with hydroxychloroquine. This was a case of severe asthma currently being managed with dupilumab and was found to have Darrier-Roussy sarcoidosis after the discontinuation of corticosteroids. The skin nodules resolved in 2 months, and the hypercalcemia was managed by IV fluids, calcitonin, and zoledronic acid.
Oh my gosh, absolutely incredible. I don't think I've ever heard of this variant of sarcoid. That's definitely at the limit of my knowledge. Promise, how did that feel, and what do you think of the case evolution?
If I could describe this in one word, I think it's very fun, and I would encourage anyone in the audience to try. I mean, going in, I was like very nervous, and I feel like I don't know anything compared to everyone here, but I think it's such a great learning opportunity, and it's like to kind of just see where I'm at and how far I've grown from, when I first joined and discussed. I don't know if you remember this, Robbie, but when I first discussed, like, I couldn't even talk about any pathology just because I haven't learned anything yet. And to this point, I think I'm happy with my learning progress. And it's just recognizing that it's always, medicine is a journey, and it's always learning. We're all learning from each other, and just have fun in the process.
I just wanted to say a little words about Darrier-Roussy. Darrier-Roussy is a rare manifestation of sarcoidosis characterized by subcutaneous nodules commonly found in the upper extremities. Classically, the lesions present as asymptomatic, firm, mobile subcutaneous nodules without epidermal changes. And the first case report published was of a patient who had presented with cutaneous sarcoidosis while being treated with omalizumab after being weaned off steroids.
Promise, my internet cut out for a second, which is classic at the VA, so I had to reconnect. But I warmed my heart to hear what you said. I think that the real question is, why do we do this? Like, why are 40 people here in the middle of their day or the beginning of their day hanging out and talking about a case like this that's already been solved, and the patient's already gotten great care from folks we admire? And it really is to just reflect on the fact that we're all learning and growing it, and that we're all trying to find the margins of our knowledge to be that much better the next time. And that growth begins well before you start to see patients in the clinical years of medical school. That growth is happening all the time. And I think it's so cool to see you do this in particular, Promise, because you're symbolic of that very mission, is to say that anyone, even people who have never seen a patient before, can start to practice their diagnostic skills. And here you are now, showcasing how much tremendous growth you've had, but more importantly, how much excitement you have to grow even more. And I think you found your growth arc. You were very comfortable in solving this case and said, hey, you know what? I know that this is a pathway with vitamin D, but I don't know what the DDX for that pathway is. And it's really, really cool to see you do that. For me, my growth arc is, I'm still uncomfortable with distinguishing between sarcoid and its mimickers. And I think knowing that there's a specific variant of sarcoid that Andrea just taught us about will help me in easing that tension next time. So the fact that this is so characteristically described will probably make it easier to not worry about lymphoma in this case. So that's my growth arc. And every single time you do a case, I guarantee you find something that is at the limit of where you're growing. So thank you, Andrea and Ravi, for working together to help Promise and I find our places to grow. And I hope all of you have found yours today. But there's nothing like re-emphasizing our growth and going through the teaching points. So Yasmin, take us home, please.
Wow, this was an amazing case, amazing discussion. Promise, you were great. Like, honestly, I don't think I could have done it. Like the Jasmine from like third year school med student would have never. But yeah, so let's go to the teaching points. First of all, when we have a patient like this, we have to look at the localization of the masses in the rash. And Promise did a great job pointing like if there was exposure, where is this rash? And the nodules, then we went to see, we have to think that this is a deep process. So the inflammatory skin nodules arise from inflamed blood vessels or adipose tissues, and they either can arise in response to underlying infection or antigen stimulation with influx of inflammatory cells. Then we went to see that this patient had a vitaminosis D that made us suspect of granulomatous diseases, which could be sarcoidosis, Crohn vasculitis, foreign body exposure. There are infectious causes of granulomatous or fungal exposure. And we went more towards sarcoidosis, which can cause a calcium dysregulation that we can see in this patient with a severe hypercalcemia that activates the macrophages producing this enzyme 1-alpha hydroxylase and causing hypervitaminosis D, which we were looking at in this patient. The final diagnosis was diarrhea disease, which is a sarcoidosis with subcutaneous nodules, which is a very uncommon variant affecting between 1.4 to 6% of patients with systemic sarcoidosis. And the skin manifestations vary and may include papules, scar-associated sarcoidosis, erythema nodosum, lupus pernio, plaques, subcutaneous nodules at this patient. So it's a very rare manifestation. And we have to see that the first case report published was of a patient who had presented with cutaneous sarcoidosis while being treated with omalizumab after being weaned off steroids. So these are the teaching points for today. And great case, everyone. Thank you, Dr. Ravi and Andrea. They were amazing.
Bye, thank you.
Take care.